and hopefully you leave here with a lot more knowledge about kidneys and kidney disease than before coming in. Any special requests before we get rolling? I do that sometimes. All right. So we have two kidneys, left and right. The left kidney is a little lower than the right one. No, the right one is lower. Just some nerdy notes here. The liver, the liver is a big organ, and it does push the right kidney down a little bit. So they're not at the same level. Before I keep going, there's one thing that came to mind now that I gotta address. I hear this question a lot. Hey doc, I got some back pain, and I think it's my kidney. No, it's not your kidney until proven otherwise. Be assured, rest assured, it's not your kidneys. If we have some back pain, nagging back pain, chronic, comes and goes, it almost always is not kidneys. Muscle, joint, cartilage, arthritis, other things, not the kidneys. If the kidneys are causing the pain, folks are really sick. If the pain is coming from the kidneys, then it usually, a sicker situation than the nagging pain, recurrent pain, chronic pain. I just wanted to get that out of the way. All right. The kidneys get their main blood supply directly from the aorta through some arteries, and they give the cleaner and leaner blood back to that big vein also directly. And the stuff that they filter comes down the ureters, two little tubes down into the bladder. Bladders are much bigger than this, it's a tiny one, but this is where the urine is stored and then at intervals comes out of the body. What I think you'll learn today, early signs of kidney disease, number one. See, I on purpose put in there signs, not symptoms. Why? Because there are really no symptoms for kidney disease unless, there's advanced kidney disease or kidney failure. There are no symptoms. So there's some signs, and we'll talk about those. How common conditions like diabetes and high blood pressure can cause kidney problems. And what can we do? Some tips to help the kidneys keep going. And then the really good news about the way we manage kidney disease that came out or started to be the mainstream in the last 2 to 3 years. So kidney disease management has changed over the last 2 to 3 years, and it had not changed for decades until just 2021, 2022. So I'll share with you some of these achievements, some of these advancements. What do kidneys do? This is the best picture I could come up with, so sorry. All right. What do? Let's see. Any volunteers?
They filter the blood.
They filter the blood. What else? Can you be more specific? This is not a quiz.
The fluid level in our body.
Yes. Great. So filtration, cleanup, and managing the fluid balance, the water balance. But there are other things too. Did I put them in? Yes. So they regulate electrolytes, minerals, maintain balance for these, remove waste, byproducts of metabolism. You don't want them to stay in your body. So the kidneys are one of the organs that does that. Liver does that too, but the kidneys do it much better. Liver. Of course, we recover the urine from that. But they also have some hormonal functions. They're organs that produce hormones. They're not big-time thyroid glands or like other organs that their main function is to produce hormones. But on the side, they do a few things. And these are some examples. They also activate vitamin D, by the way. So the vitamin D that you take, it goes into the blood, goes into the kidneys, and the kidneys make it changed it to a usable form by the body. And they do other things like help the liver maintain the blood sugar, and they also help us get rid of drugs or some substances that we don't want in the body. Insulin, for example, I want to touch on that a little bit. Insulin. A lot of folks need insulin. A lot of folks take insulin. Great drug. The kidneys are the one that metabolize the insulin, meaning they cut it, they clip it, they make it manageable, and we get rid of it. That's why folks need another dose at night or the next morning of insulin. You take a shot, you need a shot every day or twice a day, sometimes more. So the kidneys are the one that keep the balance of some drugs, some substances, including insulin. And that's important in one situation. When the kidney function goes down and we're still taking insulin, kidney function going down over months or years for some folks, we need to make sure to change, update, and sometimes, a lot of times, reduce the dosage of insulin. Otherwise, we may end up with a lot of insulin staying around and the blood sugars may go down. Remember, kidney function goes down, the metabolizing function of the kidneys goes down, and some things may build up, like insulin. Always check with your doctors, managing the insulin, managing diabetes. I don't. But I warn everyone to please pay attention to the blood sugar and the insulin dosage if you have advanced kidney disease. So this is called a nephron. A nephron is a set of connected pieces of tissue that make up a unit that does the work in the kidneys. So these are the workhorses in the kidneys. Don't worry about the details in there. They're not meant for you. How many of these do we have in each kidney, you think? Those are your kind of factories, your workhorses, as I said, where blood goes in, it gets worked on, it gets changed and things added, subtracted, and then it leaves that nephron in a better state. Any volunteers?
Thousands.
No?
Thousands.
Thousands? Yes, but not close. Hundreds of thousands. So each kidney is supposed to have 1 million of these. And I'll come to that. The reason I mentioned this, I'll come to it later. And the number of nephron and the amount of normal kidney tissue varies between folks. It depends on whether you were born as a mature baby yourself or prematurely, whether your weight when you were born was adequate, normal baby, or low weight. Whether you're big, tall, a lot of muscles, a lot of bones. The size of the kidney and the number of these nephrons, and hence the ability of the kidneys to do their work, is affected by all of that. Of course, bigger bodies need bigger kidneys, more work to be done. We'll get back to the nephron because that's important. The amount and the number of these that are still functional is very important down the road. If we have kidney malfunction, if we have scarring of the kidneys, less of those are available to do the work. Hence, less or lower ability of the kidneys to clean the blood. How do we measure kidney function? For that, I need volunteers. Come on, guys. How do we measure it? How do we know how much the kidneys are doing? And this is a trick question.
TVFR.
I heard all the good answers, but the answer to this question is, how do we measure kidney function? We don't. We estimate the kidney function. There's really no realistic way to measure the kidney function. Some labs and some big centers can measure kidney function to close to what it is, but we estimate it. So we estimate it really by doing a blood test. And that blood test is the MDF or the EGFR, estimated GFR, based on the blood creatinine level. So the blood test, it measures the creatinine. Creatinine, I'm going to dwell on this for a few moments. Creatinine is a substance, it's a chemical in the body. It's constantly produced by the body, but it's mainly removed. We get rid of it via the kidney. The kidneys do that. They clean it out. So if the level of the creatinine in the blood is high or going up, that's kind of like waste product building up. That means the kidneys are not doing a good job. And measuring that and plugging it into a formula kind of estimates how much the kidneys are doing with that job. Another way we can not measure kidney function, but get an idea how the kidneys are doing is by testing the urine. There are many different tests for the urine. There's just regular urine analysis. We test drugs into the urine, but we also measure the protein. And the star protein in the urine is the albumin, and the blood too. So albumin is a protein. We measure that, and that gives us an idea about how the kidneys are doing. You see that term CKD a lot, CKD. CKD means chronic kidney disease. It just means kidney insufficiency. All right, so the blood test typically tells us how the kidneys are doing, and we take that number and we plug it into a staging scheme. Stage 1 and 2 are typically mild kidney insufficiency. Stage 3 is moderate. Some of you know this because I keep preaching that. And stage 4 is when the kidney function is really low. We call that severe kidney disease. And stage 5 kidney disease is when the kidney function is so low that we got to do something. And that typically includes kidney transplantation or dialysis. And this is the same thing. Now you may be wondering, all right, what's mild kidney disease? Mild kidney disease is when we have enough evidence that there's something going on with the kidneys or something wrong with the kidneys, but the blood test for kidney function is still not bad. So when the kidney function is 60 plus, and we have evidence that the kidneys are not normal, that's what we call stage 1 and stage 2 kidney disease or mild kidney disease. From 30 to 60 is stage 3, moderate kidney disease, and then 15 to 30 is stage 4, and under 15 is typically stage 5. You don't have to worry about these details, but I thought I'd mention it because some are interested in these numbers. You may ask yourself, do my kidneys fail, or do I have kidney failure? Do I need dialysis, or do I need a kidney transplantation soon if my kidney function is 15%? The answer is no. Quick answer is no. We have a lot of folks who do well. They're doing okay. They're walking around. They come to see us. They're enjoying their grandkids' games, and their kidney function is 9% or 10% or in the low teens. They do well. So that number it kind of helps me, helps the patients decide on further action or planning treatments, but it doesn't dictate what we do and how we treat and what the next step is. It's just one of the things we use. We mainly rely on how patients are doing, how they feel, if they have some symptoms that are related to advanced kidney disease. That information is way more important than just these numbers. In some situations, we ask folks to do a 24-hour collection of the urine. That MDRD GFR that I mentioned, ACE-GFR, is largely acceptable and accurate, but not always. It can miss the mark. So at times, we may ask folks to collect the urine over 24 hours, start collecting in a jug, from morning all the way throughout the day, night, and next morning, and we send that to the lab to see, is there any discrepancy between the real kidney function and the blood test? And a lot of times that's the situation. So that's another way of us estimating or staging the kidney function. I'm going to stop here and see if anyone has any questions about these technical details before we go to the fun.
What if you only got one kidney?
Great question. Some folks are born with one kidney. Some need the kidney out for some reasons. Some patients lose their kidneys as little kids. They had an infection, they had a blockage, and it needed to come out. But whether you have one kidney or two kidneys, it doesn't really matter. We're talking here about the kidney or the kidneys as a team, as a group. How they clean the blood runs through both of them, usually at the same rate, same flow. So they do it together as a team. If you have one kidney, I guarantee you that one kidney has grown in size. If you lose a kidney, at a younger or older age, that other kidney that's there, it's gonna buckle up and it's gonna grow in size. The number of nephrons don't go up, but every single one of these grows in size. They grow muscle. They start working more. Now, most of the time, we don't end up with a kidney function that's equivalent to as if both kidneys were there. But that one kidney will bring that kidney function, cleanup function, very close to as if we have two. Yeah. Kidneys are smart. They're great. Yeah. All right.
So if you've got what they call a stacked kidney or a two-in-one instead of, I've heard it called bedroom or stacked, where there's two smaller units instead of one.
So you're talking about two kidneys on one side and maybe one or two on the other side. So again, they work as a team. We have a lot of patients that have two kidneys on one side, or the one kidney has two arteries, so kind of two blood supplies. And that's good. That's normal. That's part of normal kidney anatomy.
Like if a part of one of those would get something happen to it or get disease, the other one would be, or they're kind of opposite.
So they're different. That's such a great question. Okay. Hey, we can talk till midnight. But there's some diseases that affect the kidneys that are caused by health problems in the body, and the kidneys will get them, whether you have one kidney or two or three. But some medical kidney disease is localized, typically has to do with the flow to that kidney, in or out. In general, if you have two kidneys on one side, for example, and you get an infection or an autoimmune disease with a lot of inflammation all over your body, then both kidneys, all kidneys, available will be affected by that problem. But sometimes if you get a blood clot that affects the vessel that goes into or out of that kidney, then that's just that one kidney. Yeah. Now, to lose a kidney completely without trying to salvage it, now it's rare. As long as you recognize there's an issue and you seek medical help, we almost always, are exceptions, we can save the kidney. Because we recognize the infection, we recognize the blockage, we can recognize the inflammation that's going on, and we can help the kidneys. There are exceptions, though. There's a limit to what we can do. Yeah.
The 24-hour urine collection, do they actually do a lab analysis of the urine, or is it just the result based on the volume? Or is it a combination of?
So the volume is important. I always want to know how much urine is being made, but just for me. No, we do a test on the urine itself, and every time you submit that test, we ask you to get your blood drawn that morning. And there's a formula that goes inside of that machine at the lab, and they use the information from the urine collection and from the blood, and that gives me the information I need. So yeah, whenever you collect the urine for this specific reason, you have to chase it with a blood test.
I thought it might just be for the volume, the amount of volume that you were looking at with the primary goal.
No, we do test actually the creatinine in the urine.
Right, okay.
Yeah. All right. All right, so when do we call it kidney failure? When the kidney function is not enough, it's so low, and we call it kidney. I don't like to call it, everyone who knows me knows I really don't like to call it kidney failure, but we hear that a lot. You're going to hear it a lot from anywhere. It's when the kidneys can't maintain balance. Homeostasis, that means balance. Electrolyte imbalances, fluid overload, other complications. There are complications of kidney disease. We'll get to that as we go. Typically, balance is disturbed enough that we cannot restore the balance with medications. We can't restore it with diet. We can't restore it with injectables. Then that's kidney failure. End-stage renal disease is when folks have kidney failure and they have started dialysis. Also needed a kidney transplant, but it's rare, but it happens that we can sometimes get patients a kidney transplant before they need to go on dialysis. If we have a good follow-up, good communication, then we can do it sometimes. Of course, no kidney transplants here. They happen in Portland and Seattle and Spokane. Remember that little guy called Nephron? The kidneys are they're resolute, they're strong. They do their best. Even if when we lose the majority of the nephrons, those functioning units, they can still do the work. You have 1 million in each kidney, you lose 900,000 of them, your kidneys will still be doing a good job. You're still going around doing whatever you do every day. But at one point, the loss crosses a level that the imbalance sets in. I get this question a lot, urine volume. When the kidneys are malfunctioning, what happens to my urine volume, my urine output? Almost always, no change. Nothing changes, except late in the disease of the kidneys, we start making less urine. The problem in this situation is not the volume, it's the quality. Quality of the urine is not good because the kidneys are not doing the cleanup. They're still producing urine, but bad quality. There's less waste excretion. We won't see it. Again, we'll still can function and go about our day until it's late. altered hormone production, that will come to that later, and reduced removal of toxins and medications. So disturbing the balance. Kidneys are all about balance. They balance things out for us. We won't see that until late in the disease. And this is the problem sometimes. Folks think, yeah, I'm doing okay, I'm feeling okay, I'm great, my kidneys are great. Well, maybe no, because you won't feel it, you won't know it, except if you just talk to the primary doctor, the experts, or do the blood test. Albuminuria, albumin. So albuminuria means albumin in the urine. And I touched on that earlier because the amount of albumin in the urine, how much the kidneys are spilling through those filters, or their own filters, into the urine is very important. A lot of albumin in the urine is a bad thing, bad sign. And it kind of gives us an idea whether the kidneys are going to be okay for a long time or not. And I wanted to talk about it real quick here. Oh, yes. This table helps us, it helps us kind of get an idea or estimate or try to predict, if you will, whether the kidney function will be okay for the long term or not. And this is based on two things. And again, some of you know this because I keep preaching it. All right, so we use two sets of labs to help us try to predict how the kidneys are going to be. The first set goes on this side, and this is your blood test, the GFR. 1 and 2, mild kidney disease. 3A, 3B, moderate. Stage 4, severe. And stage 5 is kidney failure. On the other side, and equally important, is the urine test. If we have a lot of albumin in the urine, a lot of protein spilling, that speaks for damage. A lot of albumin is on this side. A lot of damage to the filters, medium amount, and low amount of damage is here. So we plug them into this table, and I'll give you an example. Someone who has a moderate amount of kidney disease, so stage 3, but they're not spilling a lot of protein into the urine, they fall into this category. Yellow, orange. Green is very low risk. Yellow, some risk. Orange is moderate. And red, you don't want to be in the red. Red is bad. It means kidneys won't do well. While if someone has really mild kidney disease per the blood test, but they spill a high amount of protein in the urine, they're in the orange already. And we see this a lot in diabetics early on, even early on in the course of diabetes. The blood test looks great. Sometimes the urine is forgotten, but guess what? They have a lot of protein in the urine, a lot of albumin in the urine. Not good. So, if you want to know more about your kidneys, blood test is not enough. Talk to your doctors about the urine test. All right. What can we do? All right, I'm going to stop here, see if anyone has any questions so far. Oh, such a quiet crowd. All right, there's a lot we can do. Now, sometimes we can't do anything. But, yeah.
Does your urine turn different colors then?
No. So quick answer is no. However, urine color has nothing to do with the severity of the kidney disease, how bad the kidneys are. Having said that, urine color is important. It's an important guide that you can use to See if you're well hydrated or not. Remember, if your urine is yellow, you may be dehydrated. Urine has to be like lightly tinged, light yellow tinge to it. But color is not everything, okay? It can give us an idea, it can help us. Sometimes some medications that we use change the color of the urine. Food that we eat changes the color of urine, as you all know. And sometimes infections of the urine can change the color of the urine to green or purple. I've seen purple. Some bacteria, yeah? All right, so what can we do? What can be done? The best thing we can do in folks who have kidney insufficiency is to slow down the disease. Can we stop it? Rarely, if we're lucky, but we can slow it down. You bet we can slow it down. To reverse a chronic damage, an old damage to the kidneys, that's physically impossible. Because chronic damage to the kidneys is usually manifested as scarring of the kidney tissue. And scar tissue cannot become normal tissue. That's impossible. So we shoot for stability of the kidney function if we could, or at least slowing down the decline in the kidney function. How do we do that? Number one second. There are 5 things you can do to keep your kidneys happy. Some of you know what those are. 5 things. Yeah, water is important. But the number one thing we can do to help the kidneys, stabilize the kidneys, is, that's one of them, control or help other organs, other diseases that can affect the kidneys. And what are the top 2 medical problems that can cause kidney disease? Blood pressure is one. Diabetes. It's actually the other way around. Diabetes beats blood pressure in causing kidney disease, but high blood pressure is a close 2. Other health conditions like heart rhythm problems, heart failure, usually severe valve heart problems. If there's autoimmune disease, it needs to be addressed and the inflammation needs to be controlled. Liver disease, if you have a liver problem, that's also super important to control. If we have other medical problems that are not under good control, it's very hard in a lot of occasions to control the decline in the kidney function. So let's get our house in order first. Take care of the main diabetes, hypertension, heart, liver, autoimmune diseases. Doing that will help the kidneys. Will help the kidneys thrive. Blood sugar, blood glucose. BG is blood glucose. So control the blood sugar. That is probably the most important thing you can do, is control the blood sugar, control your diabetes. In addition to helping the kidneys directly, doing that almost always reduces the protein in the urine, the albumin in the urine, and improves the odds for the kidneys. Control the blood pressure. That's very important. Now, reduction of weight and staying alive, active. Ow. You gotta stay alive. So, working on the weight and staying active has not been really studied, and there are no good research studies that say it helps, but we know from expert opinion that maintaining a good weight and staying active secondary helps the kidneys by helping the heart, really. And substance abuse. We're talking about alcohol, smoking, and illicit drugs. One thing about smoking can harden the blood vessels. You want your blood vessels to be flexible as much as possible, because that's how good blood flow goes through them. Hard blood vessels can limit the flow to certain organs, including the kidneys. And the kidneys, by the way, are the most vascular organ in your body. Blood flowing to the kidneys, I'll give you an example. Both kidneys together are the size of 2/3 of your brain, give and take. However, your kidneys get 2.5 times blood flowing to them than your brain. So they're super dependent on the blood flow. And the blood flows through blood vessels, arteries, veins, right? You want them to be in the best shape. Flexible. So control the blood pressure, right? And don't smoke. So I mentioned the diabetes first on blood pressure as causes of kidney disease. And you see close to 40% of folks with advanced kidney disease or kidney failure is the diabetes. And very close to is 25% or so is the high blood pressure. And then come the other reasons why the kidney function goes down. So both together, the numbers are really close to 65, 2/3 of the causes of kidney disease are the diabetes and hypertension. All right, what else can we do? What's number 2 on that list? Limit the salt, lower sodium. Very important. We're not saying zero. You can still enjoy some salt in your food, but you got to limit it for you and for your loved ones, because low sodium also reduces the risks of heart, cardiovascular complications, and strokes. Avoid dehydration. Hypovolemia is dehydration. Now, I do not commit to a certain number of ounces or how many or liters that we need to keep it under or over to be hydrated or dehydrated. I say drink to your thirst, maybe plus an extra cup of water or 2. And use some clues, like if your mouth is dry, you may be dehydrated. If the urine is yellow, like not necessarily dark, but yellow, then you're dehydrated. I'm gonna grab this bag here. This color, dehydrated. Really has to be light. If you're not going to the bathroom except after work, once a day, you're dehydrated. You got to use the bathroom at least every 2 hours during the day. For most folks, not everyone, okay? All right. Avoidance of nephrotoxic agents. Those are medications, substance, chemicals that can directly hurt the kidneys. And the most notorious ones and available for the masses are the NSAIDs. Have you heard of NSAIDs? Non-steroidal anti-inflammatory drugs. Kidneys hate the gut of these medications. That's your ibuprofen, that's your Advil, Aleve, Motrin, naproxen, and there are like a dozen of others that we rarely use. If you're in doubt about the kidney situation, if you have high blood pressure, if you have diabetes, please stay away from these. All right. Now you need pain management, pain control. Check with the primary doctors or the pain management team for those, but don't come near them. There are other medications that we use in the hospital setting. Sometimes rare chemotherapy agents can hurt the kidneys, but these are rare, and your doctors who are prescribing them do know if they hurt the kidneys or not, and they almost always call us. Number 5. No, I gotta move faster, right? Number 5, and this is the innovation is in number 5. So there's some medications that we use to help the kidneys go further. So we talked about avoiding some medicines that may harm the kidneys. Here we're talking the opposite. Actively prescribing medications to help the kidneys. And these medications, in general, they fall into two categories. They're either diabetes medications or blood pressure medications that we prescribe for folks to help the kidneys go further. And whether patients have diabetes or not, and whether they have high blood pressure or not, whether their diabetes is controlled or not, whether the blood pressure is under good control or not, it does not matter. Patients need to still take such medications. Now, the star such medications are the new ones, new kids on the block. They're your Jardiance and Farxiga and Invokana and a couple of others that Canada has. But we don't. So these are diabetes medications. Again, I stress the importance that you know that a lot of times we're going to ask you to please take these medications. We're going to prescribe them at low doses, even if you never had diabetes, or even if you have diabetes and it's under good control. And these medications have been on the market for several years, more than 10 years, I think, for the management of diabetes. But just in 2021, 2022, we started using them for for the benefit of the kidneys. More and more insurance companies are paying for them. I think they should be generic for everyone. The VA figured it out back in 2022, and the VA system now have those as generic for veterans. But a lot of insurance companies are lagging behind. More are approving them this year than last year, but I'm hoping we're going to see more and more approved soon. The other type of medications that we prescribe to protect the kidneys are blood pressure medications of the class of your lisinopril, losartan. I don't know if you're familiar with some of these. Those medications do help the kidneys. They also reduce the protein in the urine. They're great medications, but they're a little bit less effective than the Jardiance and Farxiga. Those are star medications, superstar medication. We love them. So if you have kidney disease or you have protein in the urine, you may be asked to take these medications. And our staff here at Good Shepherd, I'm pretty sure other clinics too, we're pretty experienced in navigating the system until we get a roadblock. And we did today, but
Both of those work
we
the
try.
same way, or do both of those, or all three of those work the same way? Or can you mix them and use like Farxiga and?
So,
Okay.
great question. The question is, can you use these medications together? Can you mix these medications, or you only got to use one? Well, of the group of the diabetes medications that protect the kidneys, you can use only one. Of the blood pressure medication group that help the kidneys, you can use one. But you can certainly have both of these used, but one representative from each group. Complications. There are few complications of kidney disease, and we only see them really in the advanced stage of kidney disease. We don't see them early on. I didn't want to bug you with these, but they include anemia, low red cell count. They include abnormal bone health and makeup. They include electrolyte imbalances. If anyone has any question about complications of kidney disease, let me know. I'm going to focus on two things though. One is what we call chronic kidney disease, mineral bone disease. And this happens in advanced kidney disease, especially in folks who have high phosphorus and abnormal calcium, either high or low. You're not going to have this most likely, but if it happens, there's some testing that we do, usually blood testing, and we have a couple, three classes of medications to address that and make the bone healthier and stronger. And you see the vitamin D there, your vitamin D3 that you're taking, it helps the bone in this situation. Not always, but it can. And there are other prescription medications that we use for this. Another complication of advanced kidney disease is anemia. Anemia is low red cell count or low concentration of hemoglobin. And anemia sets in typically late in the disease, and especially if we have more advanced disease, we see it more often. And for those who have anemia, we test their blood for iron levels sometimes, among other things, and we can treat this problem with sometimes intravenous iron. If we get the complication of anemia and low iron and advanced kidney disease, oral iron doesn't work anymore. So check with us, and sometimes we use intravenous iron. But there are some injectables that will prompt the bone marrow to manufacture more red blood cells and treat the anemia. So we can help with that. This is it. We're at the summary. Wow. Any questions before? Go ahead, please.
Is any of your lecture online? Is there a link where we can just link on? Because I've been taking notes, but I mean, they're not out.
No, sorry, we keep it a secret. Can't share. Of course. Just check with any one of us at the end, and maybe if we can share the link with everyone at the end. Yeah, I'm getting an odd.
And the second question, what is the general recommendation for salt? Because you can read anything from 600 to 1200.
I tried.
A man and a woman.
So the question is, what is the recommendation for salt? How much is too much? And what's the limit? Is that your question, right? On purpose, I did not want to go into that, but I will now.
I'll look it up.
No, I'll answer you. So in general, their recommendation is to keep the salt intake to less than 2,400 milligram per day. So around 2.5 grams of sodium chloride per day. That's for folks who do not have chronic diseases like kidney disease or heart disease. However, for us, because of the increased risk of complications, we say, let's keep it under 2,000 milligram. For some folks, I restrict the sodium to less than 1,500 or even 1,200 milligram. That's very rare. That's harsh, to go to 1,200 milligram or even 1,500 milligram. If you can keep your salt, sodium chloride, that's the salt in the food. And you can read labels. All food that we buy have labels and they tell you about the sodium. If you can keep it below 2,000, you're doing great.
Is one salt better than the other if you have kidney disease?
No. Well, here, let me cut your question in two. Is some salts better than others? And right there, the answer is no. For patients with kidney disease, the answer is still no. But I want you to know this. Sodium chloride, table salt, is purified sodium chloride. Sometimes it has some iodine and other things. But it's very purified. So per pinch, you get an X amount or X milligrams of sodium chloride per pinch. Now, other salts that we see on the market, like Himalayan salt, Martian salt, I don't know. No? Sea salt, yeah. These are typically less pure forms of sodium chloride. So per pinch, you're getting less sodium chloride because it's not purified like table salt. But guess what everyone does? Not salty enough, let me get another. So ultimately, the sodium chloride consumption, whether you use purified salt or less pure salt, is the same. My advice, keep it under 2,000 milligram. If you could 1,800 milligram in some situations, you should be fine. Go ahead, yes.
Or Nexium, what do they have there?
Warfarin or Nexium?
Either, both.
Yeah, warfarin does not affect the kidney function at all. You just follow up with blood testing per the doctor or nursing team. Nexium, there's some information that came from one of my classmates in St. Louis. He found that long-term, if we take Nexium or omeprazole or Prilosec or rabeprazole or all of these medications for heartburn or for the stomach, he found a link So there's some connection with long-term, down the road, when a little bit on the older side, that we have chronic kidney disease or lower kidney function. However, the cause-effect such relationship has never been proven. So what I say to my patients is, if your doctor wants you to be on this medication, if your body needs the Nexium, please do take it, don't stop it. Sometimes we see folks that take Nexium or stomach medication for no specific reason for a much longer period of time than normal. And in those situations, if there's no need, then yeah, don't take it. Talk to your doc, primary doc. Sorry, go ahead.
What do you have your kidney patients take in place of, if you can't take ibuprofen because you have arthritis? So what do you suggest they take?
So I typically say, I'm here to help your kidneys. I'm going to tell you about medications that harm the kidneys I want you to avoid. How to treat the pain or manage the pain, that's not my territory. But I say, hey, please check with your primary care doctor. There are a lot of options other than non-steroidal drugs, ibuprofen and similar medications that can be used. And most of the time the doctors can prescribe something. Sometimes the pain cannot be controlled until a pain management team is being involved. So yeah, I typically don't answer that question. It's not really my expertise. But unofficially, if
taking ibuprofen 6 times a day or 4 times a day at the recommended dose still can mess your kidneys up.
that hurt.
I'm sorry.
4 times.
Oh, should I
Yeah.
tell you? How about the Advil 8 tablets at a
Oh
time?
my God. So that's a lot. So here's my pitch about NSAIDs. So the question is about NSAIDs, ibuprofen, and similar medication. I want you to know this, please. There are other options. Check with your primary doctor, pain management team. They'll find you something. A lot of times, pain is there and no one can do anything about it. I get that. But the majority of the times, you can be helped. But I want to say something real quick. Oh, sorry. Can you hold on to that question? I want to say something real quick about NSAIDs, ibuprofen, Advil, Aleve, Motrin, naproxen. Kidneys hate the guts of these. They hurt the kidneys. You cannot imagine. Sometimes irreversibly, sometimes after the use over a few days. We end up with permanent kidney failure from them. Rare, but it does happen. I've seen it several times. Other than that problem, these medications can raise your blood pressure. Who wants a higher blood pressure or have hypertension when, no? Well, of course, we're not talking about 1 pill or 2 pills here and there. We're talking about the habitual intake or repeated intake of such medication on a daily basis every other day and over an extended period of time. These medications do one more thing that's really bad. Independent of what I just talked about, the blood pressure and the kidneys, they raise your risk of a heart attack. And by far, not just by a fraction of a point. Folks who take these medications have much higher, I don't know the number, that's not my territory, but much higher risk of getting a heart attack. So please. I can't stand those medications. Go ahead.
You touched on the sodium intake, salt and watching your sodium. What about potassium?
So potassium is the good electrolyte, by the way, and magnesium too.
Electrolyte?
Yes,
Okay.
but hear me out. Oh, sorry.
Well, we're dietitians here, and I have a follow-up question on that, if I can.
On the potassium?
Yeah.
Okay.
So I was just gonna say, potassium is one of the electrolytes we recommend to help lower blood pressure. It's a part of the DASH diet, which stands for Dietary Approaches to Stop Hypertension, which we use a lot with people who are starting to have impaired renal function. I was gonna ask you, at what point in renal decline, do you want us to start telling people to ease back on the potassium as opposed to telling them to increase it to try to help their hypertension from making their CKD worse?
Great. I'll answer you. I have an answer.
I'm sorry.
Did she answer your question about potassium?
Not really, but.
No. Oh, sorry. All right. So potassium is the good electrolyte, and
I'm looking at it as a kidney protection, okay, and not
No.
necessarily high blood pressure, which I have high blood pressure too, so.
So let me settle this. Potassium as a supplement or in food that are rich in potassium is a good thing. For anyone really, especially if you have high blood pressure. But if you have kidney disease, it can be bad. Why? Because the kidneys are the ones that manage and balance things, especially the potassium. So at one point in time in that table, as the kidney function goes down, at one point the kidneys won't be able to manage the potassium the right way. And what happens then? Potassium builds up. If the potassium goes up, and I'll come back to you. If the potassium goes up, the heart may stop. Potassium has to be kept in a very tight, what we call therapeutic window, therapeutic range, therapy. Meaning, if it's too low below this, that's bad for the heart mainly. If it goes up, bad for the heart. And that range is pretty tight. And the kidneys do that all your life. They keep your potassium within that range and almost always smack in the middle of that range, at the center. But when the kidneys start to malfunction, then potassium builds up, and that can become a big issue, and it is. I deal with it every day with some of my patients with advanced kidney disease. So to answer you, there actually is no specific cutoff where we tell patients, hey, gotta back off. But to be on the safe side, stage 3, dial it back. Especially stage 3B. 3A, you may be able to get by, to recommend it, but 3B and below, yeah.
We get a lot of your patient referrals, so when in doubt, can we message you and say, is this one you want us to limit potassium on?
Yes, of course, anytime. All right, we're going to go through the summary, and then we'll open the floor for more questions. Okay, we have a Q&A session for probably 20 minutes. All right, so what we learned: identify chronic kidney disease, symptoms. We can't rely on them, because if we wait until the symptoms of kidney disease set in, guaranteed too late. So blood testing and urine testing, blood and urine testing, these are bread and butter testing that primary doctors do quite frequently, at least once a year. So if you're seeing your primary doctor, you're getting labs done, one of them is a kidney test. So they'll catch it, we'll catch it early on. Protein, we talked about that. We talked about how to slow the progression of kidney disease, the blood sugar, blood pressure, the salt, the hydration, avoiding the NSAIDs, and using some prescription medication that help the kidneys. Complications of kidney disease, we touched on those. Any other questions? Go ahead, please.
Omeprazole, what does that do for your, is that like Nexium?
So omeprazole is in the same exact family of Nexium. Nexium is esomeprazole. So it's the newer sister of omeprazole. If your body needs it, a lot of situations, there's gastritis, there's peptic ulcer disease. Those come with the risk of an ulcer developing in the stomach or duodenum. Then you gotta take the medicine. That linked I talked about without proof of causality. There's no cause-effect relationship yet. should not prevent patients who need to be on such medications to take it. Go ahead.
I was wondering if tirzepatide is indicated, it would cause issues with
Which medication?
tirzepatide, Mounjaro,
Oh.
Zepbound.
The question is about the group of medications that Mounjaro, Trulicity, Ozempic,
GLP-1.
Wegovy belong to. This is a newer group of medications that's available for our patients. Not very new, but newer than others. It's an injectable. It's once a week usually. And it was initially designed to treat diabetes. We call these medications GLP-1RAs. There is, as we speak, evidence that such medications help the kidneys go further. No FDA approval. We expect in June or July for some committee out of DC or New York or wherever to say, hey guys, you got to be using more and more of these. One of the problems is they're not available. They're too expensive. Because everyone wants to use them now for weight loss. They're taking those away from our patients that need them for diabetes and soon for hopefully kidney and heart health. Again, I'm not committing yet. I don't recommend those to be added to the medications to help kidneys, but I'm confident we will be doing that later this year. Now, these medications don't hurt kidneys. If anything, they help them, but we're not yet recommending that. They look like they're wonder medications. Weight loss, diabetes control, now kidney heart protection.
Alcohol use.
Yeah, dependence, exactly. Yes, ma'am.
What about metformin?
So, metformin is a safe medication to use in patients who have kidney disease until the kidney function is 30%. In the books, if you read the books, it says 40-45%. But in my experience, we've used them very, very nicely without any issues, even if the kidney function went down to 30. 30, we have to stop the metformin. Why? Metformin doesn't hurt the kidneys. Metformin itself as a chemical, as a medication, does not cause damage to the kidneys, but it can cause severe, very bad complication called metabolic acidosis that is very resistant to treatment, ends up patients sometimes in the ICU. So if the kidney function is in the middle range, you can still use it if your doctors want you to use it. But if it's on the lower side, 30 and below, you got to stop it. And your doctor will give you something to replace it. Good answer?
It'll work.
Well. All right. Any other questions?
I had one.
Yes.
You mentioned it earlier, and I didn't catch all of that, about cancer treatments, like radiation and chemotherapy, their effect on the kidneys. Or do they have one if we have to go through those treatments?
You're right. I mentioned it. There are some medications that are used for chemotherapy, or now there's immunotherapy for some cancers that can cause kidney damage. But the ones that we see are actually 2 such medications out of hundreds that the cancer doctors use. So my answer is, in general, cancer medications, chemotherapy, immunotherapy are safe to the kidneys. Radiation. Radiation therapy does not hurt the kidneys except if there's concentrated radiation to the kidneys or ureters, the outflow of the urine. If the doctors have to give you radiation in that specific area, then yeah, we will end up with scar tissue, and then we may lose some kidney function and rarely a lot of the kidney function. But radiation doctors and cancer doctors, they will have discussions with you about that if that's needed. And they will involve us typically early on to help prevent kidney damage or look at alternatives. Yes, ma'am? Go
How
ahead.
much potassium can a person have at stage 3?
All right, stage 3A or 3B?
3B.
If your potassium level in the blood is normal and you have stage 3B, then you can eat normal amounts of potassium. It's when we start overdoing it that makes me a little nervous, even with stage 3B. For sure, stage 4, stage 5, you got to be very careful. Now, we consume somewhere between 2,000 up to 4,000 milligrams of potassium in a day, regular diet. So you want to be on the low side. If you can bring it to below 3,000, that'd be great. Now, if they're worried about potassium being high, then you got to bring it below 2,000. And remember, the labels do not, almost all labels on foods do not mention potassium. So you got to know the potassium in your food yourself. Potatoes, tomatoes, bananas, guavas, papayas, peaches, oranges, prunes, raisins, beans. All these are good, except if your potassium is already high, except if you have advanced kidney disease, stage 4 or 5. So be my guest, eat them. They help the blood pressure, right?
The one thing you haven't mentioned, you mentioned drinking water, but you have to remember that flushes out everything. And when you talk about potassium, it's kind of like a silent thing. When it goes low, you just don't feel good.
Yeah.
But you never connect it to your kidneys. You just don't feel good. Been there.
Yeah, true. Typically, if we have low kidney function, the potassium is normal or high. On very rare occasions and in specific circumstances, potassium can go down. From overuse of diuretics, from lack of adequate intake of food, if we're sick or trying to lose weight, then potassium can go down. And low potassium gives you practically no symptoms until it's too late too. So we got to be careful. That's why if you have advanced kidney disease, you're taking medications that may interfere with the kidneys, I'm sending you to do a blood test in a week, right? Or 2. Bring you back to see me again in a month or 2. So we take this seriously and we monitor patients in these situations closely. But yeah, low potassium can be an issue. It's rare in advanced kidney disease, but we keep an eye on that and we test for it. Yeah. All right, go ahead, please.
What about caffeine?
Oh, you hit the good nerve. All right. If you ask the heart doctors in 2025, heart doctors, they're okay. Some of them. If you poll them in 2025, majority will say caffeine is good. Okay. With all respect, some old schoolers still say, oh, caffeine is bad, it can cause trouble to your heart, don't drink it. There's no science behind it whatsoever. But there's an exception. If you have high blood pressure and your blood pressure is not controlled, you cannot be consuming a lot of caffeine because that raises the blood pressure and makes the blood pressure more difficult to control. But if you have high blood pressure and your blood pressure is well controlled on medications, or you don't have high blood pressure issues, be my guest. And by me, be my guest, I mean 4 or 5 cups a day. Up to that, even more, 6. Now don't say Dr. Akoum said we gotta drink five. No, you can. If your blood pressure is not controlled, your max is 1.5 cups a day. Not 0, but that's a max. You want to take it to the max and your blood pressure is not controlled, don't push it too much.
What about energy drinks specifically?
So these have caffeine. You need to know how much caffeine is in them. A cup of coffee has 150 milligrams. Is that what my smart phrase says? Come on, help me out. 150. Energy drinks, they have typically 50, 65, 95. Some of them have 200 or 300 or whatever. Just be careful. Why do you need energy drinks? You got coffee, you got juice, you got water. Let the teenagers have the energy drinks. Can I take this question first? Go ahead.
What makes your, like, your GFR fluctuate, like if you have a yearly test and it fluctuates, say, like from 57 down to like 44, 43, what would make that? Is it something going on in your body, the electrolytes, or I mean, what would cause?
Yes and no.
Sometimes then it goes back up.
Yeah. So that blood test for the GFR is the best test we have to estimate the kidney function, but I don't like it at all. It's not accurate, but it is what we have. We tried for decades to get a better test. We don't have one. This test can fluctuate based on many different things. One of them is your hydration, dehydration status, the minute of the blood draw. And we're not the same. The same day, well, an hour later, half a day later, we're not the same hydration-wise. So you may get a artificially lower kidney function because you're a little bit dehydrated. 1, 2. What you have for dinner the night before can affect your morning blood test. So keep that in mind. A little bit, but not too much. Not too much, but it can affect that. Medications that you use. Sometimes we stop medicines, we up them, we lower the dose, we start new medications, and that changes that GFR, the kidney blood test. Now, having said that, the kidney function does go up and down, but as long as it's not going down and continuing to go down, if it does this, you're okay. Yeah, the fluctuation is part of normal kidney assessment. There was another question, sorry.
I read somewhere that chocolate is bad for your kidneys.
Stop reading from that website.
Oh, that's a good thing.
Chocolate is okay. Yeah, from the kidney perspective is okay. And dark chocolate really tastes good. Just some chocolates are loaded with sugar, just be careful from that respect, but they don't affect the kidneys. No.
I drive van for the non-urgent medical people, and we do a lot of dialysis. Is there anything that I might need to be aware of with our riders that go to dialysis? I know, after I need to watch that they're not bleeding, but
Nothing really specific other than what you normally monitor for other patient populations. They're typically sicker when the kidneys have failed, but
why are they so tired afterwards, you think?
not everyone is. Not every patient after dialysis is that tired like you're describing. Some are, some because dialysis is a little bit too hard on their bodies, but some because they didn't pay attention to how much liquid they consumed over the previous 2 days. So no,
It just seems like
no. Some of them have low blood pressures after dialysis. Majority have normal blood pressures. So everyone's different. Yeah. Remember, if we have, and when we get to a point where the kidneys have failed and we're on dialysis, there are other medical problems, mainly heart, sometimes liver, sometimes it's the diabetes. So, yeah. Go ahead.
What causes kidney stones?
I almost made it without that question. Almost. Bad genes you got from grandma, grandpa. But there are other reasons too. Dehydration is a risk factor for kidney stones. If you're not hydrating well, you may get a stone. Medications, some side effects of medications, they can increase the risk of stones. And of course, hereditary diseases can do it too. In our clinic, nephrology, the kidney disease clinic, we don't treat stones or stone renal colics or stone episodes. That's part of urology, the urology surgeons. They go in, they cut, they blast them. Sometimes they go in and basket them out. But what we do in nephrology is we can help patients and help the urology doctors prevent further stones, or at least reduce the risk of that. And we run some blood tests, we run some urine tests that will give us and the patient a better idea about the risk of new stones or risk of these stones getting bigger. And we prescribe sometimes medications, and sometimes we prescribe dietary changes to reduce the risk of stones. And it always works, actually. We do a good job. You had a question?
Oh, I was just gonna say, yeah, we can help with that. If we know what the stone was made out of, like if it's an oxalate or calcium stone, it really helps us figure out what you're eating or not eating.
Yeah. So I want to say something real quick about stones. All kidney stones are calcium stones. They're calcium something. Calcium oxalate, calcium citrate, hydroxyapatite, urate, whatever. So if anyone has a stone, God forbid, in the future or whatever, make sure to know what that other part is when they analyze the stone. Don't come to me and say, I have a calcium stone. Guess what? Yes, a rock is calcium something. Yes.
Does your kidney heal from that if you've had a stone?
Yes.
Okay,
Almost always it does.
yeah, because she said I had a really angry kidney.
Yeah, even big stones.
Yeah.
Oh,
I
sorry.
had to get blasted out. I don't know what the terminology is, but
Lithotripsy.
yeah.
Litho means stone, and tripsy is to trips the stone, so to blast it. But yeah, kidneys do recover almost always back to normal or to their baseline.
I don't have a question, I have a suggestion.
Yes, please.
You know me, okay. I think that you should refer your patients to a dietitian in the beginning stage of kidney failure. Because, it's pretty hard to get right information, and if you're not a computer expert, you get this side and that side, unless you go to, Kidney Foundation and stuff. But another thing, I know that's gonna put a lot of pressure on the dietitians, but then maybe you can just get one dietitian that, specializes in that.
You're bringing a very important point. Thank you.
But I got another question.
Okay.
On May the 1st is Potassium Awareness Day. You can find that on the internet. I found that last year.
Oh, wow, I did not know.
Yes, I have it down, so I'm waiting for May the 1st to, go with it this year, if I can find it again. Because
All
I
right.
have a problem with that because I didn't bookmark it.
Most patients, let me just say this, most patients with kidney insufficiency, kidney disease do not have a potassium problems. but some do. And the ones who do, it sometimes is difficult to control the potassium. Going back to your suggestion, thank you, truly. Most patients with kidney disease only have one diet restriction. One. Low sodium. That's it. However, more advanced kidney disease, I don't know if you know, they need to be on a low sodium, potassium, low sodium, low potassium, but also low phosphorus, and there are other restrictions. Once we get to a point where the kidney function is a little bit more advanced, we're adding low purine to prevent gout attacks, and low sodium and low then we do make referrals to the dietitians. We, not all the time, but for those situations, those patients, we do. This is ER. All right. If there are no more questions, thank you for coming in. And 1 second. No, wait.
Okay, is it still working?
Yes.
Okay, a round of applause for Dr.
No. Thank you.
I just want to say thank you again for being with us tonight. How many of you knew that Dr. Akoum was a top U.S. doctor? Okay, some of you did. Now, he was voted by his peers, which that means physicians across the country voted him as a top doctor, and that's Castle Connolly, the organization, and it's the top 7% in the country.
Thank you.
Okay, not only that, but he was voted by our staff as our Physician of the Year.
Thank you. I try.